So I'm Kaci McCleary. I'm a neurologist at the Health Partners Neuroscience Center. I've been here for a couple of years now. Did my training at University of Iowa and undergrad at Iowa State, which I know is controversial if anybody here's from Iowa. And then residency at University of Minnesota and fellowship training for hospice and palliative medicine at Ohio Health in Columbus, Ohio. So I just kind of wanted to talk to everybody today about what palliative care actually is, because a lot of people find it intimidating, which is understandable, right? There's a lot of association with kind of end of life and really unpleasant topics, places where people don't necessarily want to find themselves. But unfortunately, life often leads people to a place where they would benefit from the additional support that palliative medicine can offer. So let's talk about what it is, try to demystify it, try to make it a little bit less scary. So what actually is it? It is a way of practicing medicine for people with very chronic, serious, or multiple illnesses. Typically, these are ones that are life-threatening or life-limiting, not necessarily, tomorrow or next month, but even years down the road, can span from things from congestive heart failure to cancer to dementia. And I'm interested in neuropalliative care because I feel like patients with neurological conditions that threaten life tend to have a unique set of needs. And so we'll talk about that a little more later. Palliative medicine overall, the goal is to focus really on quality of life, especially if you know that quantity of life is limited or if it's unknown. If you know that this could be life-threatening, but we don't know when, that's a hard space to live in. And so, again, having that extra support is really nice for people. During palliative care, you can continue all treatments, you stay on all your medications, you would still be able to get therapy or home assistance or chemotherapy or do dialysis. Like it makes no changes to the rest of the type of medical care that you would receive, unless for some reason we find that other medical care isn't helpful to you or isn't helping you meet kind of your healthcare goals. Some general things that we can do: symptom management. There's often a team involved. So here we have social workers and a care coordinator. Other places will have chaplains or home nursing. Lots of variety of resources. We also try to work on goal setting. So I mentioned healthcare goals. We'll talk a little bit about what that actually looks like, what kind of things we're thinking about when I use the term healthcare goals. And then hospice is part of palliative care. It's generally focused on the last 6 months of life. I'll tell you a little bit more about it later. But it is not the same thing as palliative care. That if you take nothing else away from today's talk, I want you to understand that hospice is part of palliative care, but it is not the same thing as palliative care. So things that we focus on, really treating the whole person. So I'll ask people at appointments about, what are the physical problems that you're having, but also how is this affecting you emotionally? Do you have a good community? Do you have a strong religious approach to this or kind of understanding of your sickness? How has it kind of affected you as a person? To see if we can help with any of that, or at the very least, just give you a chance to express it. Fortunately, that means I get a little bit longer appointments. So I usually get an hour with people the first time and half an hour or sometimes longer for follow-ups. Other palliative care people may have even longer. Just depends on where they practice. I also will check in on symptom management. So if there's pain that's uncontrolled that's related to the illness, if people are having trouble with constipation or poor appetite, upset stomach, can't sleep, super anxious, and we're having trouble managing those, sometimes that's something that I can help with, or also help brainstorm medication or non-medication ways to manage those things. And then I'm always happy to reach out to other parts of the team. Love sending people to physical therapy. Love getting home safety evals. We have great social workers. Anything that I can connect you with, any resources that I can connect you with, I'm always happy to do that. Other things that we'll talk about that are more specific to the disease is to talk about what does your individual prognosis potentially look like. None of us has a crystal ball, but some diseases at least will have an idea of how long is someone going to live? What does the course of this look like? What symptoms do some people get versus everybody? And what kind of things do you need to plan for in the future so they don't catch you off guard? Advanced care planning is really trying to get your thoughts about what's important to you medically and in your life, who you would want to make decisions for you, getting that all in writing, so that there's no question about it if you are ever not able to speak for yourself. There's the goals of care discussion, kind of digging into what those goals actually are so you can fill out your advanced care planning paperwork. And also just deciding how might a new diagnosis impact your life. So a new diagnosis of dementia, does that change how aggressive you might want to be with something like, getting a surgery to repair an aneurysm, or how aggressively do we want to treat this cancer? It might depend based on what your other diagnoses are. And then when appropriate, I will talk to people about hospice. What does it look like? When might you start looking into enrolling someone in hospice? Ultimately, each individual hospice kind of has their own system for evaluation. There's some general criteria, but it's something that I'm comfortable answering questions about. And then why neuropalliative care? Palliative care, and particularly hospice, really originated around cancer care, because people were living longer with it and people were having a lot of very obvious uncontrolled pain and symptoms, and needed that extra level of support. Now that we're kind of understanding more diseases better, especially neurological diseases better, we're seeing that there are unique needs in this patient population. So people with Lou Gehrig's disease can have effects on their breathing or swallowing and may need a feeding tube. They may not want a feeding tube, though. They may need a breathing machine. They may not want a breathing machine. That's all stuff that we have to talk about. Planning for the future in dementia, or kind of more advanced Parkinson's disease, when people start to have symptoms that are more difficult to control. Some strokes, if they're small, not really relevant to palliative care, but people who have very large strokes, especially initially in the hospital right after that happens, often will meet with palliative care. And even multiple sclerosis, again, generally not for the majority of the course of people's diseases, but there are some people with very aggressive forms or very advanced forms that kind of continue to affect them later in life, and may have more symptoms that need management. Neuro issues tend to have some unique patterns. Different types of cancers. Again, we have kind of a general idea how a lot of those will progress, but neurologically, people can have very sudden injuries that require a lot of very sudden support, massive life change, whereas others, most types of dementia, might have a very gradual decline, where you have more time to plan for things, but also they can sneak up on you. It's almost too much time to plan. You might not realize what you need until, oh my God, now it's a crisis, and we try to avoid that. There's a lot of social stigma around neurological issues. I would say particularly dementia, but certainly all of them can have sort of invisible disabilities. So difficulty communicating, confusion, severe anxiety, like people not wanting to leave the house or not being able to leave the house without a loved one. And this kind of fear of losing one's personality or losing oneself can be very isolating, even more so than, again, cancer is the classic one. Everybody, if you say I have cancer, everybody kind of comes out of the woodwork to support you. Sometimes if you say something like I have dementia or I have Parkinson's, people don't always know what to do or how to respond to that, even if they want to help. Um, it's just something they're not as familiar with. Um, Neurological symptoms can be a little unique. Spasticity or rigidity, which is very tight, painful muscles. Seizures are a little more common in neurological disorders. There are a variety of stroke syndromes and delirium, which tends to happen if someone has an already vulnerable brain, a history of a brain injury, and then has to go to the hospital for some reason or get sick or their medications get mixed up. They can suddenly get extremely confused. And it's very startling to a lot of people who I don't know that we always do a good job of warning families that this is a thing that can happen, and what to do if it happens. And then certain diseases may need to talk about, would a feeding tube be appropriate? Is this something I would want? Would external ventilation, having a tracheostomy, that tube in the throat that allows a machine to help breathe for you long term, is that something that you would want or that would even be appropriate for your condition? Because some of them do seem to benefit from feeding tubes or external ventilation. Some of them really don't. I just wanted to run through some kind of buzzwords that I catch myself throwing around sometimes. And I think you'll start to see over and over if you start to read more about palliative care. Goals of care is a really big one. And I've said medical goals and, what are your goals? What do you want? People are like, what do I want? I don't know. Fix me. Sometimes we can't do that. So short of a cure, what things are important to you? It's going to look a little different in clinic versus in the hospital. So in clinic, it's really, hopefully the patient is participating. Hopefully you've got some friends or family there, people who would be helping make decisions in the future if that person's ever not able to. This is where we hopefully talk about things like advanced care planning, getting a power of attorney listed, both financially and medically. If you were in X situation, do you think you would want a feeding tube? So, if you were in the ICU and you had a brain injury and we didn't think you'd ever be able to speak again, do you think you would want to continue to live, or do you want to be kept comfortable in that situation? What types of things would you be willing to go through at a chance for recovery? Some people are like, I'll tough it out. Let's go. Any pain, I'll do it. Other people might say, I can't do any more pain. I've had a good life. Just keep me comfortable. It's so individualized, and it might be something that you've never thought about before somebody brings it up. It is worth noting that people are very resilient, so some things end up being a lot more tolerable than you might have expected, and some things end up being maybe worse than we might have expected. So this is all fluid. This is all a thing that needs to continue to be revisited. And the most important thing really will be on the next slide is identifying those underlying, like, what are your priorities? What makes your life worth living? What are things that you couldn't live without? And then we can use those principles to try to help make more specific decisions, because you can't predict every potential situation that's going to happen medically down the line. You can outline a few likely ones for different diseases, but we're not going to figure out everything. And then medication deprescribing is something that I really enjoy. Sometimes if you have coverage for it, we can have you meet with a medication management pharmacist to try to figure out if there's things that are overlapping, doing multiple things you don't need to be on anymore, things that are causing potentially side effects. Also, if there are medications that we feel like are maybe not useful anymore. So people on a cholesterol medication, for 30 years, the goal with that is to kind of prevent heart disease or stroke in the next 5 to 10 years. If somebody doesn't have a life expectancy of 5 to 10 years, if their life expectancy is 2 years, maybe being on that medication is not as important, and that's just one less pill they have to take. So there's some things we can do in clinic. In the hospital, these tend to be a little more dramatic. Sometimes the patient can participate. Sometimes it's their decision maker, their next of kin. if they haven't selected a power of attorney specifically, or sometimes the whole family can get involved. Those questions are usually more around, do we start or continue additional life support if someone's having trouble breathing on their own? If someone is already on a ventilator and we don't think that we can safely get them off of it, would they want to, have that external ventilator? Would they want to have a feeding tube? And then also there's this discussion of code status, which will come up in about 2 slides. Would somebody want CPR or not? And those, if you haven't done kind of the pre-planning, can be very difficult emotionally. Family might go, oh my God, we never talked about this. I have no idea what this person would want in this situation. And so that's some of the goal of what I like to try to do in clinic, is get out ahead of that, so that if someone does end up in the hospital and the doctors turn to their loved one and say, well, what would he want in this situation? You have a decent answer for that, and it doesn't feel like you're just guessing or like you're making the decision for them. How do I know my goals? This is not always obvious to people. Again, it's kind of not something that you think about on a day-to-day basis. If you're not sure, there are some healthcare values worksheets out there. There's some toolkits. I've got some links on the last slide that people can use to go to some of these websites, but there's certainly other ones. The Conversation Project's pretty good. That's kind of how to talk about what your values are with your family. Because even if you're comfortable thinking about this on your own, it might be kind of an awkward thing to bring up, like at the dinner table. Like, how do I have this conversation? When do I have this conversation? Who needs to be part of it? Those are all things that they have kind of tips and tricks on. The Go Wish cards are kind of a fun way to do it. It has a list of all of the priorities that people might have, and then you kind of pick them out and remove the ones that are less important to you and kind of narrow it down to, a handful of, like, these are really the most important things to me. So some examples of those are things like avoiding pain and suffering. Other people are going to say, I want to live as long as possible. I don't care if it's uncomfortable. I don't care if I'm like unconscious. Like, I want to be around as long as possible. Some people will say, well, I want to make it to my kid's high school graduation, or, my grandson's got a concert in May. I want to make it to that. And then we try to focus on those specific individual goals. So you might be more aggressive with life sustaining or life extending treatments before that. Okay, we made it to the wedding or the graduation. Now I'm more comfortable kind of de-escalating some of those things that are trying to keep me alive and focusing more on the comfort part. Some people contributing to medical research or teaching is very important to them. So, well, I can't save myself, but maybe I can help prevent someone's suffering in the future. Or some people care a lot about being able to physically function. I need to be able to move around. I need to be able to use my hands. Versus other people say, well, like a wheelchair is fine if I can talk and watch my shows. Other people just want to be around their families. And then if there's ever a time when they can't do that, that is maybe when we would focus a little more on staying comfortable. So just some examples. Everyone is going to have totally different priorities. It's worth noting also that priorities can change over your lifetime, so it's worth revisiting these if there has been a big change. And it's also worth noting that patients and families might have different priorities. So families often really highly value keeping their loved one around or keeping their loved one safe, whereas that person themselves might be, I want to be independent as much as possible. I don't want to go to the hospital. And those may not be compatible always. So that's something that we can talk about in clinic and kind of bring the whole family together, try to problem solve or get everybody on the same page, help everybody understand their different perspectives. And then this is nice because once you know those priorities, you can ask your healthcare team how different treatment options are going to impact those goals. So if you say, well, it's really important to me that I continue to walk, how is this surgery going to affect that? So now we talk about code status, getting into a little bit more of the technical terms. This is typically regarding CPR. So if your heart stops beating, what do we do? Do we try to restart it? Or if you're having trouble breathing, would you want the tube to go down your throat to have a machine help you breathe at least temporarily while we kind of try to figure out what's going on? Most people, I mean, everyone just by default is full code. If we're not sure, we assume that someone is full code and we will try to restart a heart. We will take someone to the ICU. You would be intubated if needed. We try to keep people comfortable. Like we'll give medications for anxiety or to put people to sleep so they're not distressed. But really the focus then is on keeping someone alive. Often this will improve the short-term survival, but it won't necessarily improve someone's function. So if someone is already not getting around well, if they're having maybe advancing dementia, if they're already having a lot of heart problems, it's not going to fix any of that underlying those underlying conditions. If anything, often it will make those worse because having your heart stop, being legally dead is very, very hard on the body. And sometimes people can bounce back from it, but it's not as often or as easy as it looks in the movies. And much more often, people will have some kind of residual damage from that. There is a risk of physical harm. There are fractures, rib fractures, just to do the process of keeping the heart going. There can be internal bleeding. If someone doesn't get oxygen for long enough, they can have brain damage. So it's, I think, very tempting to say, yeah, do everything, keep me alive, do what you can. But there are risks from that. And I think particularly for people as they get a little older or if they have a lot of chronic underlying medical conditions, CPR might not always be the best option. So if it's not the best option, then what do we do? There's kind of a middle road where we say, okay, if the heart stops, we're gonna allow natural death. Like I'm done. Let me go. But anything short of that, if my heart is still going, but I'm having trouble breathing, go ahead and put the tube in, take me to the hospital. Do antibiotics, do fluids, do shocks, do whatever you need to do short of bringing me back. And sometimes that can be indefinite and just say, keep doing whatever you need to do. Sometimes that's more of a trial where somebody will say, okay, I know that my heart doesn't work great, but maybe if I get pneumonia, and I need that tube, go ahead and put it in for a couple weeks. Let's see if we can fix that problem. Let's see if we can get me kind of on a good trajectory to recover. And if that doesn't happen, then maybe we need to revisit what are those goals and is this consistent with them? And then there are people who say, I don't want any of that. I'm done. If I'm not able to breathe on my own, keep me comfortable, let me die a natural death. So allow natural death is one that I don't see as often in adults, but I've seen it a little bit more in like pediatrics. Not a pleasant thing to think about, but unfortunately does come up. And you'll also see DNAR, do not attempt resuscitation. And some people have kind of changed to that just to really emphasize that this is not always successful. CPR is not always successful, even in the short term, depending on what the problem is, what caused the heart to stop. We are not always able to get people back, even if we're doing everything. So don't want to scare people. Certainly don't want to imply that nobody should be full code. I think it's very reasonable for most people to be. But it is a procedure. It comes with risks. And there is a point in most people's lives when we might say it's not worth it to reach the goals that I want. It's not consistent with those goals, those things that I'm trying to get out of what's left of my life. Or yeah, I just don't want to do it for whatever reason. You're allowed to say no, thank you. particularly, I think if somebody's quality of life is already borderline or if they have a low likelihood of survival, that's when somebody might change. And then just a note on like that do not resuscitate versus comfort cares. Why might somebody use one, not the other? Comfort cares is more specific than do not resuscitate. It does not mean getting worse or less care. Obviously, we're going to try to keep people as comfortable as possible, no matter what treatments we're doing to them. But some treatments are not comfortable. So with the do not resuscitate, we're trying to avoid things that will do harm or be ineffective. With do not resuscitate, comfort cares only, or really comfort focused cares, we're usually trying to keep people out of the hospital. We're trying to avoid things that are generally going to prolong life. People will sometimes still treat reversible conditions. If I choke, like fix it, do the Heimlich. But the understanding is that someone is starting to approach the end of their life, and that we really want to focus entirely on comfort rather than life extension. So that's when that's used, and there are people who will put that on their forms and then still go to the hospital, and that's okay. Nobody's going to stop you from doing that. The forms we'll talk about later are not like carved in stone or anything, but they're general guidelines for the types of care that you may or may not want. So how do I document these goals? Okay, I did the Go Wish cards. I figured them out. Where do I put this? There's a couple of forms. There's the Pulsed in Minnesota, the Post in Wisconsin. They're very similar. Other states have different ones, but they're all the same basic principle, which is documenting that code status for emergency medicine providers. Because if you have to call 911 because something has happened to your loved one, everyone is assumed to be full code unless you've got this paper. Advanced directive is great to have, but it doesn't count because 911, that's not their training. They don't have the time, in an emergency situation to like go through and double check that you're actually the power of attorney and that you've actually had these conversations. They need it documented or you're going to the hospital. People can get pretty specific in these, but you really don't have to. You can just have the general outline as well. And usually you want them in a place that's easily visible, like the refrigerator, or sometimes people will even put them above their bed if they know that they're bedbound. Healthcare power of attorney, you can do with or without the rest of the advanced directive. You can just hey, I want this person to make my decisions for me, and be done with it, or you can go through the whole. There's a longer version of the document that's got more documentation of these are my goals. This is what's important to me. If you make someone your healthcare power of attorney, please tell them that you have done so. Please try to have some of these conversations with them so that they don't one day randomly get a call out of the blue that they need to come into the hospital and make decisions for somebody that they don't know anything about healthcare wise. Maybe they know you well as a friend or family member, but you don't want somebody to go to the bedside and go, oh my God, I had no idea. Which doesn't happen often, but it does happen. So if you make somebody that, please talk to them. If you don't have a power of attorney, most states, not all of them, but many places will go by kind of who's your legal next of kin. Some states, I think Minnesota has a little bit more flexibility of trying to identify who's really closest to you, but oftentimes it will just default to like the next family member or spouse. So if that's not someone who can do that or wants to do that, please do try to get it in writing. And sometimes people may not want to. If spouses or children, or like adult children in particular, sometimes they'll say, would you be my power of attorney? And they say, I don't think I can make the decisions that you want me to make. I can't, I'm not comfortable doing that. It'll hurt me too much, to say, don't hook them up to the ventilator. And that's okay. And that's then you can find someone else who is more comfortable with saying those words for you, with making that decision for you, so that you're not accidentally putting it on a family member or a loved one that just isn't equipped to deal with that. Worth revisiting these every couple of years. Oh my God. Sorry. We have automatic lights in here. They've decided that I was sitting still for too long. recommend revisiting the physical documentation every couple of years, or if there's a major life change, if you get married, if someone dies that's in the papers, like please update them. Um, every once in a while, we'll have somebody with a directive from 2013, and they go through it and they go, it's all the same, and like that's fine, but at least you checked it. Don't let things sneak by. This is just a kind of an example of an advanced directive. There are a bunch of different ones out there, including for different states. These are usually, the healthcare advanced directive is usually just filled out with either two witnesses or a notary public, and is different from the financial or durable power of attorney. So sometimes people will say, yeah, I have a power of attorney and it's financial, and those people cannot make healthcare decisions for you. It's a different document. If you're not sure, the financial ones are usually filled out with a lawyer. And then this is an example of that POLST, the provider orders for life-sustaining treatment. And it just says, Section A, if I have no pulse, my heart is not beating, attempt or do not attempt resuscitation. Goals of treatment goes into that little more specific, is this truly comfort-focused care only? Usually helps if you do have like hospice or somebody that you can call to get symptom support then. But people will check it and just kind of play it by ear with any given situation. Or do we want to limit some treatments but not others, or do we want to just full speed ahead, everything we can to maintain life? And then Section C, or on the back for some of them, will have a little more specific things like, do I want antibiotics, or do I want tube feeding? I find those to be a little more helpful to just have that conversation with your family member. It doesn't really get used by emergency medicine that much, but if you don't have any other documentation, this is a place to put it. That's certainly better than nothing. So then this kind of second half, that's all palliative care, kind of advanced care planning type concepts. Now I do want to talk a little bit about hospice, because hospice is part of this. It's not all of it, but it is under that umbrella. You'll hear hospice and palliative medicine said together a lot. That's because a lot of the same principles apply. So goals of hospice, it's really a philosophy. It is really when someone is ready to focus on, or needs to focus on, that quality of life, knowing that you might not have as much time left as you want. The goal is often to avoid repeat hospitalizations, or get some additional resources, some extra help at home. They don't provide like full coverage or room and board, but they will often have nurses or nursing assistants, patient care, people who can come and help with things like bathing or wound care, answering medication questions. And they often will have multidisciplinary support. Other things like chaplains are very common in hospice. Sometimes they'll have music therapy if you're really lucky. Or social work, nurse navigators. There's a variety of things available. It is also a very specific kind of insurance coverage model. Like very technically, that's what it is. That's where it comes from. And so if you think that you or your loved one might be eligible for hospice, might want to enroll in hospice, you can have a kind of informational meeting with them. They'll run through, would that person meet criteria or not, that they're likely in the last 6 months of life. And then it changes basically how insurance works. So everything goes as a lump payment to the hospice, and they use that to manage all medications, all like the care assistants, all those other resources that they have. Usually then you stop going to other appointments. So you don't necessarily go to primary care anymore, or you don't go to the neurology clinic. It's all managed through the hospice. Occasionally people will have unrelated things. So someone can go on hospice and still continue dialysis if they're going on hospice for an unrelated reason. So if you're not sure, it's worth asking, because the technicalities can get a little weird, and sometimes there are workarounds for things. And then they recertify every few months to just make sure that someone is still, they think, on that path. Occasionally people will graduate from hospice if they end up doing a lot better than expected, if they if they were sick and then they kind of have a turnaround or stop some medications and end up doing a lot better. And we say maybe this person is going to live longer than we expected, and then they'll graduate you from hospice, and you can always go back on in the future if needed. But um, that's kind of how they keep track of it. They reevaluate every couple months. Things that hospice is not. It's not necessarily a death sentence. As I said, people do live on it for many months. Occasionally, people will be on it for a couple of years, and people can also graduate from it. It's not giving up. Life is going to end for all of us at some point. And so this is kind of shifting, acknowledging that and shifting your goals to what can I do with the life that's afforded to me? How do I have a good death, a peaceful death, whatever that means to me? How do I do the things that I want to do and avoid the things that I don't want to do? It might not be, fighting the cancer anymore, but now you're fighting for a good life. You're fighting for symptom control. You're fighting for something else. So it's really is a shift of mindset, and adapting to your changing circumstances. But it doesn't mean that someone is giving up on themselves or giving up on living. You really do want to focus on the living part while you've got it. That's really should be the main goal of hospice. It is not the same thing as medical aid in dying. It's not the same thing as assisted suicide, or euthanasia, which is really not legal anywhere. Medical aid in dying is legal in a couple of states, but not Minnesota. And there's some confusion with this, because there is the natural dying process can look like someone being over-sedated. So sometimes people who have worked with a hospice in the past, if they had a family member who was very sick, very encephalopathic, or confused, sleepy as end of life approach, sometimes it will feel like they're being over-medicated, when really that is just part of that dying process. People do sleep more. People do get a little more confused. And so it doesn't necessarily mean that they're being over-medicated. They're very specifically, hospices are not supposed to medicate people to death. But you might hear that because it can look that way. It can feel that way, especially when somebody is grieving. So just know that those are different, and hospice will not and is not legally allowed to hasten someone's death deliberately. Hospice does not stop or withdraw appropriate treatments. They do try to stop or withdraw inappropriate or potentially inappropriate treatments. So things that are not related to goals of care. So if somebody's on a blood thinner, they might continue that because you're not going to hospice to try to have a stroke or to try to have a pulmonary embolism. Whereas, again, going back to like the statin medication or cholesterol medication, we might say, okay, well, this is more for 5 to 10-year cardiovascular risk. We think that you're more likely to live 6 months or less. You don't need to be on this medication. So they're not going to take away things that are helpful. They're not going to take away oxygen if it's helpful. They're not going to take away insulin if you need it because you have diabetes. The goal is only to stop things that are not helping with the quality of life. This is the hospice eligibility. Very, very difficult to predict for dementia in particular, a lot easier for certain other diseases. The FAST scale is what's generally used for Alzheimer's or other types of dementia, which you can look up if you're interested. It is FAST 7A or higher, may be eligible, and that's usually when people are fully incontinent, speaking a few words or less, generally not able to do much of anything for themselves. But also, you don't want to miss that window, because if someone has maybe multiple medical conditions, if they're declining very rapidly, if you're doing everything that you can and they're still, losing weight and sleeping a ton and getting sick multiple times, those can all be signs of decline, and then you might want to look into hospice and say, is this something that you can help me with? Is this something that we would benefit from, or when should we come and do this? Any life-limiting condition technically is eligible. It's just a matter of what point someone is at in that disease. Other things that can contribute to someone being eligible for hospice would be if they have like advanced kidney failure, if they have cancer in addition to their dementia, liver failure. It's supposed to say liver failure, not live. But kind of other major medical conditions that are contributing to a loss of function and possibly shorter lifespan. About half the people in hospice are there for a couple weeks or less, but that's because they didn't start. Well, either they had a very sudden thing like a stroke, or they didn't start as soon as they could, in part because of this fear that I'm going to go on hospice and die in 3 weeks. If you start earlier when you're first eligible, you will go on hospice and not die in 3 weeks. People sometimes actually live longer because they're removing all of these extra things and they're really focusing on being alive. That joy, that engagement sometimes does seem to help people live a little longer. When to consider hospice, really it's when burdens of treatment are outweighing the benefits. You're just constantly in the hospital, you're constantly in the doctor's office, you're just taking medications all day, every day, and they're barely doing anything. You're still having tons of symptoms. You're not getting much out of that treatment and possibly approaching end of life. That's a good time to think about hospice. If your quality of life is becoming unacceptable, you're not expected to improve. Dementia, for example, or end-stage Parkinson's, does get to a point where we don't expect things to improve. People are bedridden, and we don't expect them to be able to get up and move around or do things on their own again. And if that is not acceptable to that person, if you've had that conversation and they say, I never wanted to be in this stage, that's a time when you can start to reach out and say, hey, maybe it's time to just focus on comfort. Like I mentioned, the signs like decline in function or rapidly losing weight can be signs that someone's kind of approaching end of life, just very generally. And then you can self-refer or request an informational session. You don't need a doctor's referral to talk to a hospice, and you're not bound to any particular hospice. So like, just if you see me in clinic, that doesn't mean that you have to do Health Partners Hospice, for example. You can, because I'm sure they're great, but you do not have to. And then if you meet with one of the hospices and you enroll, and then you're like, actually, I don't feel like I share the philosophy of care with these people, or I don't like the type of care that I'm giving or that they're giving, you can, or if your goals change, if you find out, oh, there's a wedding in 4 months and I'm actually gonna, go back on this treatment and try to get through to it, you can disenroll. Like if situations change, you can change agencies, you can stop being in hospice, go back on it later when it's more appropriate. Quick word on medical aid in dying. Like I said, this is legal in a couple of states. Other terms that you'll hear used is, death with dignity or physician-aided dying. It is different from euthanasia in that patients do self-administer medications. That's a very strict requirement. So in euthanasia, someone else is giving the medications. That cannot be done in medical aid in dying. Patient has to take it themselves, and have to have the capacity to take the medications. They have to be able to say, yes, I know what this is doing. Yes, this is what I want, and then take them. You can't like trick somebody into doing it. That would be really bad. It's a very specific type of program. There's a couple states that do that allow non-residents, but you usually have to travel to those states, and nowhere in America allows it for dementia, in part because of that capacity concern. There's also something called voluntary stopping of eating and drinking, generally considered to be, ethical if someone is doing it in the context of a life-limiting illness. In that case, you would say, well, this is not the medication, or this is not the stopping eating that's killing me. It's the terminal illness. It's the terminal diagnosis that's going to kill me either way, and I want to take some agency over when and how that happens. These are not things that are generally available to people if they do not have a terminal diagnosis. Most of the time, this is going to be supported by hospices. There are probably a few out there, or maybe some facilities that are not as comfortable with it. But most of the time, you'll be able to find support if that is something that feels correct for you or your loved one to do. There is a natural decrease in appetite and ability to absorb food and liquid near end of life. So it's not, especially for people with more advanced illness, it's not really like you're starving somebody, because that's a common concern. I don't want to starve to death. Like when you feel sick, like if you have the flu, you're not hungry. It's that same kind of loss of appetite where people stop getting the drive for food. Not necessarily the case earlier in an illness if you're trying to prevent getting to that degree of decline, but it can happen, and then can take a few days to even a few weeks to reach actual death if you stop eating and drinking. That's just a little bit more information. I'll skip it because we're running out of time. But take-home points is basically, it really is about how you live. I know I talked about death an awful lot today, but the goal is to plan for that so that you can appreciate the time that you have and have good quality for the time that you have. You can change your goals at any time. It's a really important thing to think about, but we can't predict everything. Life is going to sneak up on you. And it's okay to say, hey, things are different now. That's what I wanted then. This is what I want now. You can focus on quality of life even if you're not in hospice. And in fact, I encourage everyone to, even if you're not really in palliative care, I would like to see everyone focus a little more on our quality of life. It's just that becomes particularly necessary when people do get these really serious life-limiting diagnoses. Please talk to your healthcare decision makers or power of attorneys about what's important to you, so that they're not flying blind if we do ever have to ask them about that. And don't panic if somebody says, you might benefit from palliative care. It does not mean that you're going to die tomorrow. It's serious, but it could be a good thing in a tough situation. So that's kind of what our goals is. That's kind of what we're here for. And this is just a resource list. If you are, oops, I forgot to put anything in for hospice. That's basically just to check your local resources. All hospices have service areas, and so you have to find one that covers the area that you live in. International Neuropalliative Care Society is a group of people that also think this kind of thing is important, and are really trying to work on building education and quality of life for people living with neurodegenerative or any kind of neurological disorder. So if you're interested in that, check them out. There's some links to some advanced directive planning assistance devices, toolkits, workshops. Compassion and Choices has a lot of information about medical aid in dying and voluntary stopping of eating and drinking. They have a lot of end-of-life resources and just general information about that sort of thing. And then if you are interested in body donation, research, brain donation, I just linked the Alzheimer's Association because they have a list on there that accepts things for most neurological disorders. So people with Parkinson's also can do like the NIH Brain Bank. They've got a whole list. But also a lot of local universities will have programs. And so that's worth looking into if you want to try to stay local. That is kind of all I have. Any questions from anybody?
Thank you, Dr. McCleary. That was very informative, very detailed. I really appreciate it. Everyone listening in, if something Dr. McCleary said sparked a thought, or you're curious about how to apply this at home or with a family member or a friend of yours, go ahead and share your question in the chat, please. Dr. McCleary, I have a question for you. Can palliative care do home visits?
The answer is sometimes. So I can't, just the way that my office is set up. I can do phone or video visits. Most people, I think, can do video visits.
Mhm.
There are also home community-based palliative care programs, and they usually can do home visits. And the goal is really to target people who um, are not mobile or have trouble leaving the house, and may also not have as good access to like the telemedicine, because not everybody is super good at computers. Not
Yeah.
everybody has internet access, and so that's a good option for them as well.
So just to make sure I understood you correctly, so those community-based palliative care um, 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 care groups. Sorry, I'm lacking the correct word, but
That's okay.
those people more often, or those groups, teams are more often likely to be able to do home visits.
Correct. Yeah. So you
Okay,
just have to
yes,
ask, does this clinic offer home visits, or is there like a separate service for it?
right.
And then hospice is generally at home or at the facility where you already live.
Okay,
It's not a place that you go to.
okay, good to know. Um, and then I have one more follow-up question. What is the difference between a pain clinic and palliative care?
Yeah, so I've definitely heard this one before, because palliative care does try to do symptom management, including pain management. So people say, well, if I've got chronic pain from like bad neuropathy or like bad back pain, like why can't you manage that? Um, some of it is a big part of it is the chronicity of the pain, like how long is the pain going to last? Again, is this somebody with 6 months to 3 years or 8 years that we're expecting to live, or is this like a 30-year-old who's going to be around for 50 years? We're going to want to manage that differently. Different types of pain also respond better to different treatments. So somebody with chronic fractures or something, maybe it's reasonable for them to be on opioids long term, but somebody who has something without a clear physiologic reason, and they're just kind of having generalized pain,
Mhm.
opioids, for example, can make those worse. And so that's managed pretty differently in something like palliative care versus more of a general pain clinic.
That makes
Pain clinic
sense.
actually has more resources as well. They have people who can do injections. Sometimes they can do physical therapy or massage therapy or acupuncture. They have more access to devices like TENS units or
Mhm.
that sort of thing, pain psychology. So they have a little more resources for the general pain management. And I will send palliative patients to pain clinic if I want them to have access to those things.
That sounds wonderful. Thank you. We are running out of time. I would like to thank everyone so much for joining us today, and a big thank you to you, Dr. McCleary, for sharing your expertise on such an important topic. It was wonderful to have you with us, and we're grateful for the insight and compassion you brought to the conversation. As a reminder, our group will be taking a summer break from May through August. We hope the months ahead bring you rest and ease. We will be back together again on Wednesday, September 16th, and we look forward to seeing you then. I'm wishing everyone a safe, peaceful, and restorative summer. Take care.